Welcome everyone. I'm Sarah Jewell, the Assistant Director of Clinical Services and Manager of the Myra Mahon Patient Resource Center. I'm thrilled to welcome you to another health seminar at the MMPRC. The Myra Mahon Patient Resource Center aims to make accurate science-based health information easily available so that patients and their families can make informed decisions about their care. I'd now like to introduce our speaker for our seminar on anti-obesity medications. Ann Jablonski, DNP, FNP-C, is a nurse practitioner specializing in endocrinology, diabetes metabolism, and weight management. She received her nursing degree from Samuel Merritt University in California and her Doctor of Nursing practice at the University of Arizona. She is a board-certified family nurse practitioner. Her goal is to provide resources and education to empower patients to make their own informed decisions. Please welcome Ann Jablonski.
Good afternoon, everyone. Thank you all for coming. Like Sarah said, my name is Ann. I am one of the nurse practitioners here at the Division of Endocrinology and the Comprehensive Weight Control Center. I am delighted to introduce to everyone some common anti-obesity medications. If at any point you can't hear me, please let me know. As Sarah mentioned, I would appreciate if all questions were reserved until the end. I would also like to thank the Myra Mahon Patient Resource Center and the Advanced Practice Provider Council for their support. So let's get started. I don't have any financial disclosures. Here's the agenda for the presentation. Here are the objectives. At the end of the talk, I would like everyone to understand that obesity is a disease rather than a lifestyle, and to understand that there are currently a wide variety of obesity medications available. So the introduction. So according to the Obesity Society, obesity is defined as a highly prevalent chronic disease characterized by excessive fat accumulation or distribution that presents a risk to health and requires lifelong care. So you'll notice that I underlined lifelong because it is a lifelong journey even if one is able to lose the weight. So currently the prevalence for obesity in America is about 42%. So you can see on the map on this slide, which is color-coded based on the percentage of its population that suffers from obesity. The green is anywhere under 25%, and the darker the red goes, so the more brownish red, is over 40%. So right now in New York State, the population is about 30 to 35% of adults that fall into the obese category. I've listed a few of the causes for obesity, including some of the obvious ones like lack of exercise, eating more calories than you burn off, the Western diets, and smoking. And some of the lesser known causes such as genetics, which we're now discovering more and more about. And we know that genetics play a huge role in whether one is at increased risk of obesity. There are some medications that can also cause weight gain. Lack of sleep can cause weight gain, and finally stress can cause weight gain or altered eating habits, whether it be eating less or more. We know that stress is unhealthy for the body as a whole. And the last point on this slide are the comorbidities or the associated diseases. So I've included just a few. So diabetes, one of the most common comorbidities, along with heart disease, high blood pressure, fatty liver, and some cancers. So obesity is a significant risk factor in the development of these health issues. This means that a person with obesity is at a higher risk of developing these comorbidities, but that doesn't mean that the person will actually develop these diseases, and vice versa, a person can have these health problems without being obese. If these health problems are associated with obesity, however, they were more than likely to improve when the person loses weight. So now I want to talk a little bit about the hormones that control hunger and satiety. Satiety is the feeling of fullness. So here is a visual of some of the hormones that control hunger and satiety. So when you're hungry, the stomach releases a hunger hormone called ghrelin. Ghrelin goes to the brain, tells it that it's empty and it's hungry, and this prompts the person to eat. Once the person eats, the stomach is full and the gut releases a number of different satiety or fullness hormones, which include, among others, GLP and GIP. And this tells the brain that it's time to stop eating. So fat cells release a hormone called leptin into the blood, which is another satiety hormone. And this is important because the level of leptin in your blood correlates with how much fat tissue you have. So I wanted to very quickly go over bariatric surgery and different types that are available, because this is still the gold standard in treating obesity. So starting from left to right, we have a gastric band, which is also called a lap band. And it's a band that goes around the stomach to decrease the size and slows down the rate of food, which helps the person feel full faster. It's a silicone ring that goes around, that is attached to a port under the person's skin. So if any adjustments are needed, tightening or loosening, the surgeon just goes through that port to make the adjustment. The second one is a vertical sleeve gastrectomy. The surgeon cuts the stomach vertically and essentially reduces the physical size of the stomach. This produces less ghrelin, which is the hunger hormone, and since the capacity is smaller, it allows the person to feel full faster. The Roux-en-Y, which is also called the gastric bypass, probably the most common or most well heard of weight loss surgery. It basically involves the surgeon taking the very top of the stomach, removing it, and attaching it to the beginning of the small intestine. So the person is left with a very, very small pouch for a stomach, and the rest of the stomach is bypassed, but it's left in the body in order to continue producing the necessary digestive enzymes that are needed. This can help with acid reflux and diabetes, and weight loss can be anywhere up to 70%. So the last two are the same surgeries, but they just have a slight tweak to it. So the biliopancreatic diversion is a surgery where the stomach is removed and the remaining part of the stomach is attached to the lower portion of the small intestine, so that the food consumed basically bypasses most of the small intestine. These are high-risk surgeries. They're not done very frequently anymore because food is no longer absorbed properly, and this can lead to a lot of diarrhea. And people who have this surgery have to take vitamins and minerals for the rest of their lives. So again, the biliopancreatic diversion with the duodenal switch, the surgery starts with a sleeve gastrectomy, so that leaves the pylorus intact. The pylorus is the valve that controls food drainage from the stomach into the small intestine, and it's connected to the lower segment of the intestine. So the upper part of the intestine is then connected to the lower part of the small intestines. So then the food you eat also bypasses much of the small intestine, and again, they will need supplements for the rest of their lives. So here's a better picture of what the procedure actually looks like. So without the switch on the right, and then with the switch on the left, and you can see the arrows pointing in the direction of where the food goes. So time for a crash course history in anti-obesity medication. So back in like the 50s, 60s, amphetamines were used as an appetite suppressant. So the movie Requiem for a Dream, if anyone has seen it, is a really good example of how amphetamines are used to cause weight loss. And these include desoephedrine and diethopropion and phentermine. And the only one that's still in use is the phentermine. So fast forwarding to the 70s and 80s, there's another medication that came out called fenfluramine, which was actually an antidepressant, and it caused appetite suppressant as a side effect, and it was pulled from the market because it had cardiac side effects. So in Europe, there were two that came out, both antidepressants. It was sibutramine and rimonabant, and both were recalled because they caused heart problems and psychiatric problems. But things get a little bit better in the 90s when the FDA approves orlistat, which is an over-the-counter medication. You can still find it in stores. It's called Xenical or Ali, and the way that it works is it blocks pancreatic enzymes so that your body has a harder time absorbing fat. A person can lose up to 5 to 10 pounds within the first 6 months if they respond well to it, but some of the side effects are, again, stomach-related nausea, diarrhea, bloating. Alright, so I kind of want to go into what's on the market right now, and starting with the oral agents, or the pills. So metformin is a well-known diabetes medication that's been around for a long, long time. It has an off-label use for weight loss, and it is very inexpensive. And this is the first line that we use often in the clinic. Bupropion is another useful oral agent. It is it can be used for a multitude of psychiatric issues like depression, ADD, anxiety, smoking cessation, and it suppresses appetite. First approved in the 80s, it works by blocking the pleasure signals in the brain. So naltrexone is another medication that's used for smoking cessation, and it works very similarly as bupropion, which it blocks pleasure signals in the brain. There is a combination of the two together, and it's called Contrave, and it's been around since the mid-2000s, so like 2014. Phentermine, which I mentioned in the previous slide, has been around it is an effective appetite suppressant, but it is derived from amphetamines, so it should be used carefully. Side effects are anxiety, heart pounding, and jitteriness. It can also cause high blood pressure, and it should not be used in those with high blood pressure or anxiety. Topiramate or Topamax is a headache medication that's been around since the late 90s, but it has shown to be effective in appetite suppressant, especially those who tend to snack or eat at night. It causes drowsiness, so it should be taken right before you go to bed. And there's a combination of phentermine and topiramate, and it's called Casimia. So Rybelsus is the pill version of Ozempic. It is approved as a diabetes medication, so getting it covered for weight loss is really hard, but studies show that a person can still lose around 10% of their body weight. And then orlistat I mentioned before. Okay, so let's get to the good stuff, which is the injectables. All of these medication belongs to a drug class called GLP-1 receptor agonist, meaning that they support the satiety hormone and make it work longer, which slows gastric digestion, emptying, and tricks your brain into thinking that it's full. And it also helps with insulin efficiency. So I'm breaking these down into 3 generations. So the first generation injectables are your exenatides and your liraglutide, specifically the Victoza. They've been around the longest, and some patients still use them. They've sort of fallen out of favor, though, because of the newer medications that are out now. Second generations are your Saxenda, which is liraglutide, and dulaglutide. A little bit more effective than the first generation. Saxenda is still pretty popular as an off-label weight loss medication. And the third generation are your semaglutides and your tirzepatides. These are the drugs that all the celebrities use to lose weight, and the drugs that everyone wants but they can't have. So these are the medications sort of on the horizon. Most of these clinical trials, most are in clinical trials now, so they won't be available for a few more years. Going through them really quickly, the amylin analogs, these work by helping the pancreas produce more insulin and block the liver from releasing glucose, which suppresses appetite and it slows gastric emptying. Orforglipron, which is an oral GLP-1, has shown promise in trials. Retatrutide is a triple agonist GLP-1, GIP, and glucagon. It's in development and will begin trials soon. And then Rybelsus is also in a sort of upgrade phase where the company making it will create one that's 50 milligrams. Rybelsus currently goes up to 14 milligrams. And then lastly, bimagrumab, which is a monthly IV medication that helps with fat loss and protects lean muscle, which is also in clinical trials. So I wanted to close out with some of the most asked questions about these medications. So number 1 are side effects. Most common side effects are stomach-related, nausea, vomiting, bloating, gas, diarrhea, and constipation, with the 2 most common being nausea and constipation. What happens if I stop taking the medication? If you stop taking the medications, you will experience what we call a rebound weight gain, which is they regain their weight. They about 10% of the weight loss within the first few months of stopping. Nearly all of the weight loss after 1 year, and then some. So some people end up heavier than before they started the actual medication. So these are long-term commitment drugs, much like blood pressure medications. Once you stop taking them, for example, if you stop taking a blood pressure medication, your blood pressure is going to go up. So this is very much the same situation with these injectables. Will my insurance cover these medications? One, no. So Medicare and Medicaid do not cover weight loss medications. If the person has type 2 diabetes, then they might be covered. But for the most part, it's very hard to get insurance to cover it. If you have commercial insurance, it depends on the plan that the employer has opted for, as most people get their insurance through their employers. So if the employer has opted for a plan that includes weight loss medication coverage, then it will be covered. If not, then it's called a plan exclusion. So in order to find out whether you have coverage, you have to call the employer, not the insurance, because the insurance will say it's covered when it's not. Where can I find these medications? So these medications can only be prescribed by a licensed provider from a legitimate weight center. Once prescribed, they can be picked up at any local pharmacy. How much do these cost out of pocket? A lot, way too much. The average monthly cost is around $1,000 to $1,100 a month. And this is an out-of-pocket cost. If you have insurance, it's a little bit different. Can I go to a compounding pharmacy? It's not recommended that you go to a compounding pharmacy. They are not FDA regulated, and we don't know what they put into their product. However, we do have people who go to them, and they do go at their own risk. So can I take other medications and supplements? Yes, you can. Just remember that these medications slow absorption, so it may slow the absorption of the medication that you're taking. So for example, a woman of childbearing age on oral contraceptive should use a backup method for at least 4 weeks because the decreased absorption can decrease the efficacy of the oral contraceptive. So I wanted to introduce the staff of the Comprehensive Weight Control Center, led by our fearless leader, Dr. Louis Aroni, who opened the center in 1986. We have Dr. Alpana Shukla, whom I support, is the Director of Clinical Research. She heads many of the clinical drug trials that our center is involved in. We have 6 other amazing physicians, 3 fellows who work closely with the attendings, 3 very knowledgeable nurse practitioners, and 3 amazing nutritionists who are all here to help support the patients on their weight loss journey. And here is the phone number of the CWCC. We are also accepting new patients. We take almost all insurances except for Dr. Aroni, who does not take insurance. So, my references. And I know this is a lot of information, and I hope you gained some insight into obesity as a disease and the weight loss medications available. Thank you again for attending, and I will now take questions.